You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. Hi all, and welcome to this special edition of the OCD Stories podcast. Now, this is the third one in the series of 4 for the month of October, and in it I invited Dr. Patrick McGrath, Head of Clinical Services at NOCD, to be my guest interviewer. And of course, Patrick has been on the show a couple of times, and he interviewed me, maybe a year ago, maybe a bit longer, and I just really enjoyed his interview style. I really liked how curious and open he was. It was a pleasure to be interviewed by him. So it was a no-brainer to get him to guest host one of my shows. And in it, he chose to interview Dr. Alec Pollard. Now, I've had Alec on my radar for a long time. I've been very aware of the work he's done and wanted to get him on for a while. So I'm glad that Patrick finally did it for me. But Alec is founding director of the Center for OCD and Anxiety-Related Disorders. Alec has been doing this a long time, and I mean that as a compliment. He's very, very well researched, and his contributions are many to the field. So I think you're going to enjoy this one. But in particular, he talks about his therapy story, what areas of OCD have his interest currently, developing an approach to help families of loved ones who refuse therapy, developing his OCD Institute in St. Louis, why it's exposure and response prevention, not exposure therapy, the importance of the RP of ERP, the influence of Joseph Wolpe to OCD therapy, how anger inhibits anxiety, panic disorder, learning to adapt to uncertainty, and much more. I really enjoyed this conversation, and with all of these special episodes, I'm hearing these for the first time when I get sent the files. So it's really cool to experience that alongside you guys. And thank you as always to NOCD for supporting the show and the work that I do. And NOCD now operate in the USA, the UK, Australia, and parts of Canada. So if you want to find out more about their therapy services, head to go.treatmyocd.com/the OCD stories, or click the link in the episode description. So thank you to both of them. I deeply appreciate their time and the work they do. And of course, I deeply appreciate your time. Thank you so much for listening. And without further ado, here is Dr. Patrick McGrath interviewing Dr. Alec Pollard.
Hello, everyone. This is Patrick McGrath, clinical psychologist at NOCD, and welcome to the OCD Stories podcast. I'm excited to have with me today Dr. Alec Pollard. Not only is he very well known in the OCD community, but he was my mentor and my postdoc supervisor, and probably the person at fault for getting me into the OCD world, if we want to put some blame on anyone. So thank you for that, Alec. I highly appreciate it. I wanted to start off today, Alec, and say, first of all, thank you for doing this. It's a pleasure, as always, to get to spend some time and speak with you. But let's start at the beginning. What is your therapy story? What got you into working with OCD, and what has kind of led you to where you're at today with a few things that we'll discuss later on?
Well, it is a bit of luck, to be honest with you. Maybe that's true for a lot of folks. Mm-hmm. I had finished my dissertation. It was on chronic pain. And I realized as soon as I finished it that I have no interest in chronic pain, do not want a career in chronic pain, and I don't really want to experience chronic pain, to be quite frank.
Oh, yeah.
So then I thought, well, okay, nice going. You just devoted your dissertation to a subject you don't want to do. So what do I really like to do? Who are the patients that I've gotten the most out of working with? And I thought about anxiety in general, and in particular OCD. So then I thought, well, okay, where can I get this training? Where can I go? And I was single and mobile, and I could go anywhere. And fortunately, I got accepted for a postdoctoral fellowship at my favorite first choice, which was the behavior therapy unit and at Temple University at the time in Philadelphia.
Mm-hmm.
And I got the extreme honor of being able to be mentored by not just Edna Foa, but all of her staff, which included the likes of Gail Steckity and John Grayson and Charlie Mansueto, and many, many more. And then also, I had the pleasure of being mentored also by Joseph Wolpe, who is considered the father of behavior therapy. So that was a great treat for me, and that just changed my life forever. I knew within one day that I was in the right place and working with the kinds of patients and problems that I really, truly enjoy. And I was very lucky for them to have taken me without any background at that point, no formal background in OCD or anxiety. I didn't have any publications in that area or anything. All the stuff I was doing was in chronic pain, but somehow I tricked them into thinking I have potential. The fools, they bought it. At any rate, so that's how I got into OCD, and then I spent a year there, and then I wanted to go start my own thing, and I looked for an opportunity, wanted to be at a medical center. St. Louis University School of Medicine was looking for someone to develop an anxiety and OCD program, and I raised my hand and said, pick me. And they did, and I've been here ever since.
So you are a one-job guy. Rare these days.
It is. Yeah. It is. When you've got a good thing, why go somewhere else? Besides, if I even thought about moving from St. Louis, my wife would cut me off at the knees because, and this was probably true before, but it's especially true once we had grandkids that are here. So that's it.
You're not exaggerating. I know your wife, Heidi, and she would actually do that. Yes, yeah.
Oh, in a minute. Yeah, I'd be down in a flash. Yeah. So yeah, St. Louis bound we are.
So now the clinic started at the university, and then over time you got your own building, and then you've kind of had some relationship with the university, correct? And then became more standalone. There's been some iterations in that, correct?
Oh yeah. Yeah. We've had different homes within St. Louis. We were at St. Louis University Medical Center in the Department of Psychiatry and Human Behavior for 13, 14 years during the 80s and the early 90s. And again, I know what your audience is thinking. In no way, he's way too young to have been there that early, and I thank them all for thinking that. But yes, I was a child prodigy, way ahead of my time. But at any rate, at the end of that period of time in the mid 90s, we had some philosophical differences with the chair of the department at that time, and decided to form our own institute. And we remained affiliated with the university. We went academically into family medicine and formed an institute, and still today have a relationship with the university. Several of us teach there and have faculty appointments. So yeah, we've remained connected to the university all of this time, although our specific home. We now, in 1995, we started St. Louis Behavioral Medicine Institute, a group of us, which is an interplay of different programs that are specialty programs. Of course, I was a director of the OCD and Anxiety Center, and then we have eating disorders. We have all sorts of specialty programs with different directors. And now I am proud to say that I have handed over the directorship as of this summer to Dr. Allison Minotti and her capable hands. She's terrific. And I am the founding director. That's my official title. And it's a very, very stressful job, founding director.
No doubt. Yeah.
No, you're I can't even begin to iterate how many responsibilities I have as founding director. It would take up the whole show. Uh, just suffice to say that the life of a founding director is always stressful and engaging.
The parade duties themselves are overwhelming.
Oh yeah, and
yes,
the groundbreakings. When we break ground on a new building, I've got to be there. It's
exactly
it's on and on. It's tough, but no, actually, I'm very happy. It gives me more time to write, and I'm delighted to give up the administrative responsibilities for our program. If delight is probably not the right word, is there a word that's stronger than that?
Exuberantly ecstatic, maybe?
maybe a little bit delusional. I don't know how excited I am.
Wonderful. Well, with that writing and looking at kind of your interests, obviously now with passing the baton a bit, and what a baton it was, by the way. It was a beautiful baton, but passing that baton on, what are the interests currently? Because I know, you and I have had many discussions, but I think it would be very interesting for all of our listeners here to really talk about what those areas are that you're really interested in now that you've been speaking about more recently. And you have some books that will be coming out as well, too, to help therapists address some of these concerns. So maybe switching to that would be interesting.
Sure. Well, I don't know when it exactly occurred, but probably sometime in the 90s. At some point, my particular interest shifted to the people that, when you're first starting out, you want to have successes, you want to treat people successfully, and you focus on that. But at some point, I really started to think about the people we don't do so well with, the people that either that won't accept treatment, avoid it like the plague, or people who come and ask for treatment, but then there's just something missing. Something's not connecting. They're not through any fault of their own, but they struggle to really effectively engage in treatment. And so those folks became my interest, the people that we, for lack of a better word, that we fail with. And so that's really been my major interest over the last, 20 years or so. And it's kind of gone in two directions. One is the people who come in, they say they want therapy, but they have trouble really, truly participating. And that's exhibited in something we call treatment interfering behaviors, just things that the behaviors they engage in that are just truly incompatible with recovery. It might be not being always forthcoming about how their anxiety is or whether they did their homework. It might be not doing their homework, being honest about it, but just not doing their homework, and having trouble following through when they're not supervised by someone. It might be missing sessions. That's kind of interfering with treatment. Recent research, you probably heard it, illustrates that patients who actually show up for therapy do much better than patients who do not. I know.
Groundbreaking.
Yeah. I wanted to wait for your show to really get that research, those research findings. And if anybody wants copies of the reprints, I'm happy to send them to you. It's just a couple of sentences.
Shortest paper ever.
Yeah. We didn't even need to run subjects, actually. We just figured it's so obvious, we'll just produce it and publish it. So there's a bunch of behaviors. I just listed a few. My favorite with teenagers is I don't know. I don't know if you've heard that before.
I don't know if I have. I don't know.
Yeah, there you go. Yeah. Why are you here, Johnny? I don't know.
I don't know.
How can I help you? I don't know. Well, your parents must have thought something was wrong. I don't know. There would be another tip. So there's many of them. You know them, you love them. Any therapist knows them. And well, maybe they don't love them, but they know them. And so those became my interest. How do we help those folks? And began to recognize that there were conditions under which we probably need to stop working on the OCD. and switch gears and work on the issues that are keeping them from engaging in treatment effectively. So that's kind of one area. And then the other area are the treatment refusers, people that actually won't come in to see us. Now, you might think, well, how in the heck do you treat them? I mean, they're not even there. And I've already given you the results of that study. When patients aren't there, the therapy doesn't go as well. So what the heck are you doing with those folks? Well, we drive to their house and berate them. All right. That's no. Okay. What we do is
you make the postdocs drive to the house and berate them.
That's true. That's true. Yeah. And if they can't do it, then the graduate students.
Exactly.
So we treat the people who seem motivated and worried about the problem, which is the family members.
Right.
And they were calling us, like everyone else. My husband, my son, my father has OCD, but he won't get help. He doesn't think it's a problem, or he thinks he can handle it on his own. It's ruining the family because, and I can give you 100 different stories of how it ruins the family or harms it at least. And then it makes it worse when a person is what we call a recovery avoider, when they engage in behaviors that are incompatible with recovery, including not going to get help. So, at any rate, we realized after many sessions of telling families, "I'm sorry, we can't help you. If the person doesn't want help, there's nothing we can do," and that would be the standard line if you called a therapist today. Unfortunately,
Sure.
Well, we found that wholly unsatisfying, and we started to talk about maybe we ought to try to help the families because they too are the victims of OCD. Even if they don't have OCD, they have to deal with its consequences. So we started putting together some ideas about how we might help them, and then we experimented with some strategies, and then we did a study, and we compared it to a educational intervention with families, and we got some good results. But then we also learned a little bit about how we need to modify it. So it's gone through more than one or two modifications till what we think we have now is a pretty good package of approaches with a menu of approaches that families can. Some families won't need every part of the treatment approach, but we invite the families in. Whoever's interested and wants to change how you approach the person who is recovering, who is avoiding recovery. But we only let those who are interested in changing how they approach. If they're open to the ideas that we have, if they're not, then we just say, you don't need to attend. We're just going to work with the family members who are on board. And that's what we do. And then we help them improve the quality of their life. And sometimes also improve the quality of the OCD sufferer as well.
And you do this virtually, correct? You can.
Well, right now we do, yeah.
Okay.
And we certainly have done it in person. The nice thing about the virtual is that there's not many people doing this work in the country. So that means that anybody from anywhere in the country, we can try to help them in their situation. So that's been a nice, one of those unexpected advantages of the COVID-19.
You talked about 20 years ago and really getting into the readiness for treatment, and I had the privilege of being there 20 years ago when we started our very first readiness group we did for patients who were in the intensive program, who were, as I like to say, fixing to get ready to do therapy, but weren't quite ready to do it yet. So
right. That's right. Yeah, that was a back then, and it's gone through several iterations over the years, depending sometimes just on practical issues. When we were having a higher percentage of people from out of town coming in, and I don't remember if that coincided when you were there or not, we would do things several times a week intensively. And at one point, we did daily
I was there when it was daily, and that's how we started it. We had from 1 to 3, we did a daily readiness group for a few people every day.
Yeah, and that was practical because, again, remember in person versus virtual. That wasn't a thing then. But that was like if somebody had come from Idaho to live in St. Louis and do treatment, and we decided that they weren't ready for OCD treatment, they needed readiness work, to have them in a hotel all week, coming in once a week, for readiness therapy didn't seem very efficient. So we had more of we developed this intensive version of the readiness. Yeah. Now we have fewer, both because of virtual and just because of so many more programs are available now. People don't have to travel as much as they did back then. And because there's usually going to be a program, an intensive outpatient program closer to where they live. So we don't have as much demand for the daily readiness with people, staying in hotels.
Right.
Yeah.
The growth of the Institute, maybe to kind of look at it from a historical kind of standpoint here a little bit. I mean, you've expanded, you have the building next door now too, your staff has grown. Mm-hmm. How do you look at that? I mean, from starting it back at the university, and if I remember correctly, you were in a basement.
At first we were. Actually, we wanted the basement because, we had a choice. We could be in the second or the first or the second floor, but be spread out. Our staff, they didn't have an area that could put all our staff together. So we could choose. We could either have staff all over the building, but not in this, or we could have our area with a centralized reception. Yeah. And that meant going down into the dungeon, what was Wool Center back then. But we preferred that because we could all have our own area. To do stuff. And there was the basement, so to speak, of the hospital had a tunnel that connected the rest of the medical center. So when we were doing exposures and it's winter, we just walked through the tunnel and to find all those great triggers that hospital medical centers are very replete with.
Right. Always wonderful to find an old bandage on the floor or something of that nature for some contamination exposures. Yes.
That's right.
Mm-hmm.
Oh, that's right. Yeah. So the Institute today now, we did a bit of a backstep when we moved because we lost some faculty. We got nervous about this new enterprise.
Sure.
The Institute and our new funding sources and our relative independence from the medical center. So some people got nervous about it. And so we lost some folks. And also we lost our inpatient unit, but that was probably because of managed care going to be gone in. We had our own cognitive behavioral inpatient unit and so when we moved, and then on top of that, the building, now get this, you never hear this. The contractor was behind schedule. No, you hardly ever hear that.
That's never happened before.
So when we were supposed to move in, they weren't ready, so we had to go to the building next door, which happened to be empty, and we had makeshift offices for a month or two, and we probably had 2 or 3 intensive patients, in this with walls built in boxes, So in a sense, we went from 2 or 3 patients in the IOP, and now we have 16 every day in the IOP, and then hundreds of outpatients every week. So I'm just talking about the anxiety group, not the. And then during the pandemic, we kept growing, even though we're all virtual. And then there wasn't the issue of office space, right? So we actually hired more staff than we have offices for, counting on that some of them will elect to work virtually. But if everybody said, I want to be on site, we'd be in trouble. Mm-hmm. Okay, you guys you're young, you work in the parking lot. You got to earn an office.
That old RV in the back of your house could come in handy as a new therapy office. So, yeah.
It is, and everybody will tell you, every medical institution or everywhere, space is always an issue.
Yes. Yeah, absolutely.
You never have enough space, ever.
Hmm.
Yeah.
With the work that you're doing then in treatment interfering behaviors, one thing that you're kind of well known for of course, the therapist community is a statement often attributed to you: exposure without response prevention is not therapy, right? That notion that you can expose people all day long to things, but if they're just going to do their compulsions or their safety-seeking behaviors, then they're not going to get any better. It's just going to reinforce doing those things. Anyway, I'm wondering for therapists listening, obviously because treatment interfering behaviors and family accommodations are such a big thing, but I think another thing that's always important in really helping even newer therapists is the notion that it's not just exposure therapy, it's exposure and response prevention therapy. And I'm wondering if you could speak to that a little bit from the work you've done.
Sure. I gave a talk at the foundation, I don't know, maybe 6 or 7 years ago. And the title of it was, I just wanted to talk about that issue, the whole talk. And the title was something like a reliable formula for ineffective therapy, right. E minus RP equals 0. Yeah. And so it absolutely is the case. And I think it's less so with people who are been trained to work with OCD specifically and had some good training. But a lot of therapists who work with OCD kind of came in through the back door of anxiety, right. and maybe the E was what they learned more about, and not so much the response prevention part, which really is unfortunate because we all know that there are safety behaviors that ERP is really a treatment for all anxiety disorders, right. And really it's possible to have a phobia, some phobias without secondary avoidance, but that would only occur. Secondary avoidance is just my term for compulsions, but so primary avoidance is just not going wherever it is you're afraid to go, and secondary avoidance would be if I have to go, then I have to be sure and do X, whatever that is, wash my hands, double check, whatever. So secondary avoidances, which we now all recognize, or at least most of people who are reading the literature know that secondary avoidance are not restricted to OCD. You can have all sorts of secondary avoidances in panic disorder, and agoraphobia, and social anxiety disorder, on and on and on. And that some of the things that we think of as being more characteristic of OCD, like figuring out compulsions, the mental figuring out in your head stuff, trying to answer the unanswerable question, that those occur in other disorders. Social anxiety, what are they doing after they have a social interaction? They're trying to figure out if they said something wrong or how that person reacted to it, whether they're judged, and they're doing their own figuring out compulsion. But we have this tendency to not want to call things compulsions unless they're OCD. But
right.
We don't have a really good universal lexicon where we can use these terms interchangeably and we'll all know what we're talking about. So we sometimes have to over-explain So that what safety behaviors versus compulsions versus secondary avoidance, but they're all the same in the sense that they interfere with learning, and that's why we care, right? So, the joke I tell sometimes to illustrate this is the guy's sitting in his backyard with a lawn chair, and he happens to live in Kenosha.
I've heard of it. Yeah, I've heard of it.
Yeah. Who would have thought?
Who would have known?
Yeah, and so he's sitting there with this giant elephant gun, and his neighbor goes, "Hey, Jim, what the heck are you doing?" He says, "I'm keeping the elephants away." He said, "There's no elephants in Kenosha." He said, "Yeah, see how good it works." Mm-hmm. So now I didn't tell that to get a big laugh out of your audience, because I'm sure it's not worthy of that. But more the point that that this man believes that his safety behavior, his compulsion, having the gun out, is what's keeping the elephants away. And he'll believe that until the day he dies, unless he puts the gun away and looks and sees what happens.
Yeah.
Then you can find out that the elephants don't come whether you have the gun there or not.
Right.
And this poor man, with his bad luck, he'd put the gun away, and there would be, the circus would be in town, and the elephants would have gotten loose, and then he'd be back to doing compulsions forever. But
it's like an Alanis Morissette song, isn't it ironic, right? Yes.
Actually, she just played here this week. I didn't get to go, but I heard it was very good. So at any rate, that simply just illustrates how we can take some highly improbable event and create some superstitious behavior that we think is keeping that already improbable event from occurring, and that will make us dependent on our safety behaviors and interfere with learning. And that's why so that's one point about response prevention, that you really have to have it, or the learning is not going to take place. Now, it's helped. Inhibitory learning has helped because the models, because they've emphasized that you have to that you really have to get at the safety behaviors if you're going to really be able to help people change their expectations of safety versus danger. But really, the insight about response prevention goes way back to the laboratory. The term exposure and response prevention really came from basic laboratory research, and mice would be shown a light, and then they'd shock the cage, and so the mouse got a phobia about lights, and so all you needed was to turn the light on, and the mouse would be afraid, would engage in fear behavior. I really don't know what the mouse was afraid, because they usually don't tell you. But what we call fear behavior, they would engage, look like they were afraid. And then when they tried to extinguish the behavior, it's like, okay, let's see, you can unlearn this. It didn't work. They kept getting nervous in the presence of the light. Well, an astute researcher observed, the mouse is going to the other side of the cage. And so the mouse is learning that they don't get shocked if they go to the other side of the cage. They're not learning that there is no shock.
Right.
So they put a board to keep the mouse there, so he couldn't escape. And then he had to learn, and he did, that there was no shock. And that's what response prevention was. It's preventing the escape response. And then now we apply that to human beings, and it gets a lot more complicated. And I can testify, because for the longest time, I get sometimes literal. Mm-hmm. And so I was just putting large boards behind my patient's chair so they couldn't escape. And that was just stupid. It didn't help anything. And then, one day I went, no, it's a metaphor. You don't really need to block their escape. But you do need to find a way to block their escape metaphorically.
Right.
And that means preventing hand washing. It means cutting back on double checking. And for mental rituals, it means perhaps giving them tasks to do that interfere with the figuring out compulsion. So it's a great leap to go from rats to human beings who are very creative in how they create illusions of safety. We have to chase them down.
Right. I'd just like to know no mice or rats were harmed in the recording of this podcast.
That is true.
Yeah.
That is true. Although I gave a dirty look to one of them. But there was no physical fisticuffs involved. No.
Back to what you said on that, the safety behavior, and I use a similar version of this elephant story. I always say if you're in downtown Chicago and you see there's a guy who walks around with a 25-foot bamboo pole, and if you ask him why he has it, he says it keeps the elephants away. Same kind of thing. I think the one thing that's interesting in that, though, is like if you go to panic, we all know that patient who's got the one Xanax or benzo pill in a baggie that it's so old they'd have to snort it at this point if they wanted to even take it because it's broken down so much. And
Right.
The day they don't bring it with them because they forgot it is the day they have a panic attack. But they've created that so much because they've spent all day thinking, oh my, I forgot my benzo. What if I have a panic attack today? And then boom, they have it because they're so worked up about it. And then that's another proof for them. See, I need to have my benzo with me.
Yeah, absolutely. And that's that's kind of the rub with panic disorder, because the feared outcome is from within.
Yes.
And you can affect at least the danger signals, the physical sensations. You can create them yourself, not intentionally, but
Right.
by accident. Whereas the elephants really would require the circus being in town and getting loose and, and having to come in the neighborhood where that gentleman is. But
yes.
yeah, no, you're right. But it is, it's a great example of the phenomena.
How have you, there's a few things I want to ask you. Let me go to other one. I think for a lot of individuals, especially those who are new to the field, you talked about Joe Wolpe being really considered the father of behavioral therapy. I think it's unfortunate. There's probably a lot of students who have no idea who Joe Wolpe is. And I was wondering if maybe you could give us a little bit about Joe and the work he did and his influence on what we do today, even if not many people may know who he is anymore.
Yeah, and Joe was a fascinating guy, and he'll be in your he should be in, and I'm sure he is. And
he should be. Yes, he should be.
He should be if they. He'll be mentioned in the textbooks as his early research on fear acquisition and extinction really became models for a lot of later research. Now, Joe was not always right. Didn't turn out to be right about everything. He very much believed in, people probably know him best for systematic desensitization, which is a form of exposure. But he very much believed that you needed some counter conditioning. In other words, you needed to be in a state that's incompatible with anxiety, which is why he tried to get people in relaxed states and then expose them in imagination often. And it would also do in vivo, but and he would get people better, but it would take longer. And I think that we later learned that just good old exposure without being in a state of relaxation was plenty, and it was faster than doing all the imaginal work and the desensitization. The other thing about him that a lot of people don't know is he developed assertion training, but he conceptualized it very differently. He one of the things that he knew back then that one of the states that's incompatible with anxiety, and I think we still all recognize this, is anger, that anger inhibits anxiety. And you can think about, okay, the fight or flight. You either got to be ticked off, you're going to go fight, or you got to be afraid, you're going to go run or freeze. So he felt like when you got yourself into an assertive mode, you were generating anger. And you were then, so with people who were socially anxious, he would teach them assertion and then have them practice that, and in situations where they generally were anxious. But he saw it as a reciprocal inhibition kind of model, counter conditioning, and which is really fascinating. It later took off as a skill-based treatment. So most people, I don't think, even realize where assertion training came from, and most of it, we teach our patients assertion as a skill. We don't think of it as a deconditioning paradigm,
right?
So that was another really interesting thing. And he formed the behavior therapy unit, which was the premier research and clinical unit on behavioral treatments in the country at the time. And as I said, I mentioned some of the people who happened to be there. And if you ever get a list of the people who trained there, it's remarkable. I mean, names that went on to be very stellar individuals in the field all over the country.
Barring yourself, of course. Yes. But,
oh no, yeah. I said stellar. I'm working on substellar. I'm trying to get or hypostellar.
Hypostellar.
Yeah. Mm-hmm. So I want you to know you don't know this, but I'm internationally renowned.
Oh.
There's a couple of people in Lithuania who actually have heard of me. And
okay. Well,
I consider that international.
I'm going to go with it. Yes, absolutely. Congratulations.
No, thank you. Very proud of that.
One of the things you said, which I think is interesting, because I remember on postdoc year one, we were teaching everybody diaphragmatic breathing and muscle relaxation when we were doing the intensive program. And then there was a couple of weeks where we had some really intense discussions and supervision in our group meetings. And then suddenly the loop tapes went away that were me and you recording, take a deep breath and hold it. And we got rid of the diaphragmatic breathing, the muscle relaxation. And yeah, people got better faster and they had lower relapse rates. And it was really fascinating to have watched going from one way that we did ERP to this newer way of just eliminating all of that stuff and seeing how well it actually worked.
Yeah, and it speaks to, again, the issue of iatrogenic effects, meaning that doctors and therapists can make people worse. And people in the psychotherapy field, I think, sometimes like to think they have a benign enterprise, that unlike medicine, psychotherapy doesn't have side effects. Yeah. And I think that belittles the power of what we do. And it makes you not attentive to the potential dangers of, for example, teaching people secondary avoidances, right? So you just gave a great example. Now, not every patient that used breathing used it in a compulsive way. Not everybody.
Correct.
Fair enough. Mm-hmm. That's fine. But why tempt them? And some of them will, especially if panic disorder. So because the fear is from within, right?
Yep.
So you have to be careful about breathing techniques that could be that elephant gun. Oh, the only reason I haven't had a heart attack is because I did my breathing right, not because I'm not going to have a heart attack. And those are the things we have to be concerned about. We know certain cognitive interventions that are fine in many situations, including even the beginning of therapy, pre-ERP, are not okay after you've started ERP. They end up becoming potential to be a compulsion. Thought stopping is another one, right? And I've always thought that one was obvious, because you're teaching a compulsion to bang away your thoughts rather than get used to your thoughts and accept them. But even if it even if it didn't do that, I've always been critical of having the rubber band on your wrist. It should be on your forehead. That's where your thoughts are, right?
Right.
So I never understood, why are we slapping our wrists? We should slap our foreheads. At any rate, that's a technical thing. We don't have to get into that. But now watch. Statistically, there's going to be one therapist out there, who is going to start putting rubber bands on his patients' foreheads. And it's a joke. Yeah. Don't do it.
Don't do that. Yeah.
Okay. Yeah, don't do it at all. So the point here is that what we do is not benign. We can cause harm, and we need to get smarter and better and keep learning and learning, because we've all done things in the past that we later went, that was not good. And we want to keep improving, and we may discover something we're doing now. 5 years from now, we may discover that wasn't a good thing.
Mm-hmm. I think what you said too, the introduction of the notions around inhibitory learning versus habituation are kind of along those lines. We used to maybe think someone who wasn't habituating wasn't benefiting from treatment, and maybe they had a belief change potentially, but we were seeing the fact that they were still highly anxious outwardly and expressing that as treatment failure, when maybe it was not. And unfortunately, that might have even been expressed to the patient that, well, this hasn't worked because you're still appearing to be anxious in this situation.
Yes, and I agree. And in particularly, depending on the type of fear, there's when you, and really the inhibitory learning has several things that are new, and then several things. Every movement, every new way of looking at the world has overlap with even the old behavioral models, and has some unique contributions. And but so, for example, the idea of changing expectancies that's not really much different than just confirming your beliefs from a cognitive model. What I think the nuance is, and I've seen people explicate it besides myself, is you have to formulate your core fear in a way that you have a clear expectation, and that whatever you're doing in exposure is actually going to test that. Mm-hmm. So you can't, going back to this is another one where I had my insight, like, oh, okay, my scrupulous patients are getting better. But wait a minute, their core fear was going to hell. All right, so I'm not really teaching them and through ERP that they're not going to hell. How are they getting better? What are they learning? Because all of our models, it doesn't matter whether it's ACT or cognitive behavioral, they're all based on learning, some kind of learning that is the curative factor or the change factor, the mechanism. So what are they learning? Well, okay, that's when we started to recognize the role of uncertainty more, and they're learning to live with uncertainty. So your fears, at least for uncertainty types of distress, have to be conceptualized as the outcomes of uncertainty, and what they expect will happen if they don't resolve the uncertainty and make it certain what they think will happen. And so the core fears have to really articulate that, so you know what you're actually going to learn when you do the exposure. You're not going to learn you're not going to hell, but you can learn that even without ever resolving the uncertainty, the distress that you have right now can pass.
Yes.
And you don't necessarily lose it or snap or anything in a state of uncertainty. You can learn to adapt to that and get on with your life. And so, all of these models have also, forced us to think, at least forced me to think more clearly about how I articulate core fears for patients. There are situations where what they say they fear, they really fear. So, bridge phobia. So guy says, I'm afraid the bridge is going to collapse. Okay. That's cool. We can test that.
Yeah.
Let's go over the bridge and see where the bridge collapses. Okay, great. It didn't collapse. You can see that. That would be one category of fears. Fears of proximal, identifiable outcomes that you can actually test. So that's category 1. Category 2, these are all, I've just made this up in my head. It's not accepted lexicon. It's Pollardian category that even aliens from other planets can't understand, really. So category 2 is, I know what I'm afraid of, but I can't tell you when or where it's going to happen. And that's the uncertainty category, right? So first one is, I know what I'm afraid of, and I can tell you when it's going to happen. Mm-hmm. The bridge is going to collapse when I go over.
Right.
Category 2. And by the way, that category 1, there's not much OCD. It's actually the least likely for OCD.
Right.
But you see it in specific phobias. Yeah. Category 2 is the uncertainty, right? I know what I'm afraid of, but it's not verifiable. I don't know when it's going to happen. And there's no feedback loop that tells me it's happened. So like someday I might get cancer or, whatever, the vague things that are not testable. Those are uncertainty. So the core fears have to reflect the uncertainty. And then the third category is, I don't know what I'm afraid of. I don't even think I am afraid. I just don't like the feeling.
Yeah.
And that's the just right, disgust spectrum, where the fear is of the feeling. And
that could be panic too, potentially, right?
Yeah, but usually they can say, I think I'm going to have a heart attack.
Sure.
Or I'm going to go crazy, right?
Sure.
But it could be, yeah. Mm-hmm. Yeah. So, and I would encourage your listeners, by the way, if because I'm not stuck on those 3 categories. It's just I keep mentioning them when I do talks and asking people if you could think of another category. If you have a patient that doesn't fit one of those 3, mm-hmm. I'm happy to change the model a little bit. But it seems like most fears, nobody's come up to me and said, "Well, I have a patient who doesn't fit either of those 3." And by the way, I should say that they're not orthogonal. In other words, you could have more than one category of fear. So if I'm a postpartum mom and I'm having bad thoughts about my child, I could be afraid that if I think it, I'll do it, and that's testable, right? That could be category 1, or I could also be the uncertainty. Like, what does it say about me as a person? What kind of person would have these? Now that invites the figuring out, and all the, and they may or may not even be worried they're going to act on the thought, mm-hmm. but just thoughts themselves are abhorrent and disgusting. And why would any good mother have such thoughts?
Right. Well, there are a few things that our founder of the OCD Stories podcast, Stuart Ralph. Thank you, Stuart, for letting me come in and pinch hit for you for this one. There's always a few questions that he likes to ask at the end. So he's asked that I ask you these questions as well, too. So the first one is this. If you could pick up the phone and call your 20-year-old self, what would you tell him?
Oh, my goodness. Besides get a hair transplant, I probably would, I'm not sure, I wouldn't tell him stuff that I've learned since back then, because that was part of the discovery, that was the excitement, is discovering things through life. So I'm probably telling him to put more money away, in a 401k.
Okay, very good.
Yeah.
You have a billboard. What do you want written on it?
Oh my goodness. Well, that would change probably in a few months when the 2 books we're working on come out, I hope. I would want the 2 books on that billboard.
There you go.
And but other than that, I'd probably go for something schmaltzy, some message of people loving each other or take care of each other. I figure it can't hurt. Most people ignore it, but maybe even one or two people go, "Hey, that's a good idea."
There we go.
I think I'll be nice to people.
And do you have titles for those books that you'd like to announce to our listeners?
Well, we do. I suppose it could change, but the one is for families of treatment refusers, recovery avoiders. There's 4 families. It's also will be for therapists who are working with families, but it's called The Family Trap: When Someone You Love Won't Get Help.
Gotcha.
And the second one is for people who have failed in therapy. It's called When Therapy Doesn't Work.
There you go.
And 5 obstacles to effective psychotherapy and how to overcome. So it's really looking at the major reasons why people have ineffective therapy and letting them sort of kind of read through the book and self-diagnose which one they think is their reason. And certainly one of the chapters is on treatment interfering behavior.
Of course.
Yeah. And but we also talk about therapists too and their treatment interfering behaviors.
Sure.
Yeah. Not that you or I have ever had any, but some of those other scallywags have.
Got to watch out for them.
They ought to be ashamed of themselves. Yeah.
And finally, is there anything else you wish you could have said today?
No. Actually, I think we covered some pretty important points. I'm sure I'll think of something half an hour from now when it's too late.
Well, Dr. Alec Pollard, founding director of the COARD, the Center there for OCD and Anxiety at the St. Louis Behavioral Medicine Institute. It has been a pleasure to speak with you today, and thank you much for joining me in this discussion.
Thank you, Patrick. It's always a pleasure to talk with you, and now I must get back to the overwhelming duties of a founding.
Thank you for listening to this week's podcast. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. And thank you to NOCD for supporting our work. If you want to find out more about NOCD, head to go.treatmyocd.com/theOCD stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.